Assalamualaikum and a very good morning to all participants. Welcome to the virtual regional anesthesia workshop for trauma and emergency. This webinar is a collaboration between the UJRA team of the emergency department of HKL and the SIGRA team from the Department of Anesthesia Intensive Care HKL. First and foremost, on behalf of UGRA, I would like to express our utmost gratitude to the anesthesia team in their tireless contribution in the effort to establish regional anesthesia in the emergency department. We would also like to extend our thanks to the sponsors, Aspen Medical, Gats Healthcare, Bron, Intan Bakti, Infinity Medical, Gemilang Asia, GE and IDS Medical Systems for their support of this program. The objective of this webinar is to provide clinicians a new modality of pain control in the emergency setting. RA is definitely not something strange in the world of the operating theatres, and we are very privileged today to have a panel of speakers who are no doubt experts in this field and also very eager to impart their knowledge and experience to those present today. For today's session, we will be listening to a series of lectures focusing on chest, shoulder, and hip trauma. Each of these sessions will be followed by a demo of the respective blocks. At the end of the lectures, we will have a live Q&A session. Throughout the webinar, you will be able to type in your questions at the chat box, and we will do our very best to accommodate all of them. A few housekeeping points to keep in mind before we begin. First of all, please mute your microphones so as not to interrupt the speakers throughout the whole session. For questions, please type in the following format. Please state your full name, where you're from, and followed by the question. This is an important point. Please register your attendance by scanning the QR code on the screen or clicking the link in that's displayed on the chat box. This is necessary to claim your CPD points. Please put your full name and IC. We'll be giving reminders of this throughout the whole session and also in the chat box. Finally, please check your emails for the e-certs in the coming weeks. To officiate the opening of this webinar, I would like to invite Dr. Mahada Abdul Wahab, the Head of Service, Emergency Medicine and Trauma, and Head of Department ED HKL, to give his opening remarks. Dipersilakan, Datuk.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. And a very good morning to all speakers and participants. It is my pleasure to welcome all of you to this first virtual regional anesthesia workshop for emergency and trauma. This event is jointly organized by OGRA EDHKL with Malaysian Special Interest Group of Regional Anesthesia. I would like to extend my gratitude and greatest appreciation to the organizing committee for making this workshop possible. To our eminent speakers and colleagues from the anesthesiology department, thank you so much for the ongoing support. Without you, this workshop will not be possible. To our sponsors, Aspen and Brown, thank you for your support, and terima kasih dahun keladi. Lain kali, tolong sponsor lagi. Pain management, as all of us know, is a very challenging issue, and majority of our patients presented to ED with pain. And to manage pain, it requires sound fundamental knowledge and skills, and the need to increase the armamentarium to ensure multiple approaches of pain relief can be offered to our patients. Therefore, RA provides us another approach or methods of pain relief with much lesser side effect in comparison to conventional analgesia in a selected patient. Furthermore, incorporating ultrasound has made this procedure safer and accessible to many. This is another proud development in emergency medicine that, again, thank you very much to our colleagues that make it possible. We have been working very closely with SIGRA HKL in training our medical officers and specialists, and we have successfully instituted ultrasound-guided RA services in our emergency department for nearly a year. And we are hoping these services can be offered consistently with a very much safer practices at the back of our mind. Finally, again, thank you so much to all the speakers and participants, and with the word Bismillahirrahmanirrahim, I officiate our first virtual regional anesthesia workshop 2020. I wish everyone a fruitful workshop and a pleasant day, and may God continue to bless our effort. Assalamualaikum warahmatullahi ta'ala wabarakatuh, and have a nice workshop.
Waalaikumsalam, and thank you very much, Dr. Madar. Before we begin, I would like to introduce our 6 speakers for the day. Our first speaker will be Dr. Eng Zetek, an anesthesiologist from HKL. He's currently a trainee in Regional Anesthesia Subspecialty Program in HKL since 2019. He's actively involved in postgraduate teaching in HKL. Next up, we would have Dr. Sabri bin Dewa. Currently working in KPJ Rawang Specialist Hospital, Dr. Sabri had undergone a fellowship in RA in Shimane University Hospital, Japan. We also have Dr. Wan Nabila binti Nik Nabil. Dr. Nabila holds an International Diploma of Regional Anesthesia and Analgesia from University of Montpellier, France, and also a trainee in RA subspecialty in HKL. I would also like to introduce Dr. Khairul Izzam bin Muslim, an anesthesiologist in HKL. Dr. Khairul receives fellowship of Regional Anesthesia from Kyorin University Hospital, Japan, has been a facilitator for various RA workshops since 2017. We also have Dr. Azrin Muhammad Azidin. He is the convener of Malaysian SIGRA, Special Intergroup of Regional Anesthesia, and Dr. Azrin holds various portfolios including robotic surgery and training for the Masters of Anesthesiology. Last but not least, we have Dr. Amiruddin Nik Muhammad Kamil. He's a member of the European Society of Regional Anesthesia and Pain Therapy and is currently the Director of Regional Anesthesia Subspecialty Training in MOH. So we will move on to the first presentation of the day, which will be presented by Dr. Eng. The topic will be shoulder trauma. Before we begin, let me just reiterate the few housekeeping points. Please mute all your mics. Please register by the QR code or in the link that is displayed in the chat box. This is for your CPD points. Please put in your full name and IC. Without further ado, I would like to welcome Dr. Eng for his talk. Welcome, Dr. Eng.
Okay. Thank you. I would like to thank the organizing committee for giving me this opportunity to give a talk here. So today I'm going to talk about this regional anesthesia for the shoulder. We can actually give good regional anesthesia to the shoulder by blocking the brachial plexus via 2 approaches. One is the interscalene approach, and number 2 is the supraclavicular approach. So for the interscalene block, we are actually blocking the brachial plexus at the area of the nerve roots, okay, which is here, this level, right? So by providing an interscalene block, we will actually be blocking the shoulder at the block will distribution is mainly at the upper arm and the shoulder. For the interscalene block, the sonal anatomy that we need to see is actually the interscalene groove. At the interscalene groove, the brachial plexus which is at the roots of the brachial plexus, lies lateral to the carotid artery and also the internal jugular vein. So the prevertebral fascia, superficial cervical plexus, sternocleidomastoid muscle are seen superficial to the roots of the brachial plexus. The depth that is usually about 1 to 3 centimeters. It's a very superficial block. Okay. So this is a picture to show the brachial plexus at the interscalene groove, which we can identify the nerve roots of the brachial plexus. We usually look at it as a traffic lights or butterfly sign. So this will be the brachial plexus, which is the body of the butterfly, or traffic light. Then this is the middle scalene muscle. This is the anterior scalene muscle. So usually what we need to do to perform this block is actually we need a high frequency linear probe, a short bevel block needle, which is about 22 gauge, and the length of the needle is usually about 50 mm. So the other equipment needed are standard monitoring, block tray, resuscitation trolley, and you perform the block under aseptic technique using a chlorhexidine 0.5%. scanning technique, there are two techniques to visualize the interscalene groove. One is the medial to lateral technique. The other one is to trace back from the supraclavicular fossa. So the medial to lateral technique, usually the patient will be lying in the supine position with the head turned 45 degrees towards the contralateral side. You place the probe on the level of the cricoid cartilage in the transverse to obtain a transverse view. Then you slide medial to lateral. So this is the usual position of the probe on the neck and the patient lying with the head turned away from the side to be blocked. So the first view you'll see is the trachea with the carotid artery and the sternocleidomastoid muscle. And as you slide laterally, more and more lateral, you start to visualize the anterior scalene muscle coming into the view of the ultrasound. As you slide more lateral, the middle scalene muscle also come into view. So in between the anterior scalene muscle and the middle scalene muscle are the roots of the brachial plexus. This is where we will do the block. How about the tracing from the supraclavicular fossa technique? The patient usually also same position in the supine position with the head turned 45 degrees. Then for this technique, you place the probe over the supraclavicular fossa and you identify the brachial plexus lateral to the subclavian artery. Then you slide your probe in a capillate direction. So this is how we place the probe in the supraclavicular fossa, and we identify the brachial plexus or lateral or to the subclavian artery. Then as you slide your probe to the capillate position, the anterior scalene muscle and middle scalene muscle come into view, and you'll see the whole roots of the brachial plexus. So how do you identify which nerve root is which? So usually you can increase the depth and look at the transverse process to differentiate which is the C5 to C7 nerve roots. Usually the C5 and C5, C6 transverse process are U-shaped, whereas for the C7 transverse process, the anterior transverse process is not present. You are not able to visualize it. So this is how we differentiate the nerve roots. And for your information, sometimes the C5 and C7 nerve roots tend to split, and you may misinterpret as two nerve roots. So if you inject between the two nerve roots, you might be injecting at the one root which split into two, and this might cause nerve injury. So this is what I meant just now by differentiating the nerve roots using the transverse process. For C5 and C6, it is U-shaped. C7, the anterior transverse process cannot be visualized. So the other thing is you need to be careful is blood vessels. Usually there are a lot of arteries that traverse this at this level. One of it being the dorsal scapular artery, superficial cervical artery, and transverse cervical artery. So this is a picture, ultrasound view of the interscalene groove. This is the interscalene groove, the scalenus muscle with the roots of the brachial plexus. However, there is the transcervical artery superficial to it. So this will make the block difficult. So how do you conduct the block? First, you confirm the landmark via ultrasound, and then under aseptic technique, you do an in-plane lateral to medial injection with aiming the needle between the C5 and C6 roots. A subtle pop will be encountered when the needle enter the interscalene groove. So the objective of the block is to place infiltrate local anesthetic between the anterior and middle scalene muscle. A successful block is determined by the plexus being pushed medially with hypoechoic spread adjacent to the nerve roots. For your information, this complete circumferential spread around the plexus is not necessary for a block to be successful. All right. So this is a picture to illustrate the block. So we place the LA the needle will transverse the middle scalene muscle, and the tip should be placed between the C5 and C6 nerve roots, and the LA should spread between the middle scalene muscle and anterior scalene muscle, pushing the nerve roots medially. As I say, complete circumferential spread may not be necessary. So dosages of local anesthetic, usually the volume of local anesthetic we use is between 5 to 10 mils, because with ultrasound we can accurately place the local anesthetic, so we can reduce the volume required to produce the block. So for the concentration of local anesthesia, if you are doing a surgical anesthesia, you might require a higher dosage, a higher concentration, ropivacaine between 0.5 to 0.75%, levobupivacaine 0.5%. However, for analgesia, you can use a lower concentration, ropivacaine being 0.2, levobupivacaine being 0.25%. The complications, this block actually is a block with a lot of complications. You can actually have like Horner syndrome, phrenic nerve block, recurrent laryngeal nerve block, epidural or subarachnoid injection, hematoma, intravascular injection, local anesthetic toxicity, pneumothorax, and also nerve injury. But with the use of ultrasound, I think the incidence of complications can be reduced. Next, we move on to the supraclavicular block. Okay. So for the supraclavicular block, for the supraclavicular block, we are actually aiming to infiltrate local anesthesia above the clavicle at the level of the trunk of the brachial plexus. So the block distribution for this block, actually the distribution of the block is actually the whole upper limb except the proximal medial side of the arm. It also can provide a good analgesia or anesthesia for the shoulder, but not as dense as the interscalene block. So how do you identify the brachial plexus at the supraclavicular level? Because the subclavian artery crosses over the first rib between the insertion of the anterior and middle scalene muscle, posterior to the clavicle, so you're able to identify the brachial plexus in relation to the subclavian artery and also the pleura and also the rib. So how you identify the rib? It is an acoustic shadow, and then the image view deep to the rib appears anechoic. For the pleura, you are able to identify sliding sign. Okay. So it is often possible to see the fascia shift of the muscles surrounding the brachial plexus. And at this level, the brachial plexus can be seen as a bundle of hypoechoic round nodule, just posterior superficial to the artery. We use the artery as a guide to identify the brachial plexus. We are looking at usually about the depth of between 1 to 3 centimeters. This is also a very superficial level block. So this is the picture, the ultrasound anatomy to illustrate the brachial plexus at the supraclavicular level. So we identify first the subclavian artery, and then the first rib. So below the rib, you cannot see there's an acoustic shadow. There's nothing can be viewed because it's bone. The ultrasound cannot penetrate it. Then the pleura, you can see sliding sign. So the brachial plexus is viewed like a grape-like structure. Okay, superficial, posterior to the subclavian artery. So equipment is the same, similar to the interscalene block. But we use a high frequency linear probe, but the needle length need to be a bit longer. So we usually pick about between 80 mm to 100 mm. You can also use 50 mm in smaller patients. So but the scanning technique, however, the patient need not to be in the propped up position. You can perform the block in the supine position, semi-sitting or slight lateral position with the head turned away from the site to be blocked. Something like this. So well, with this block, you will put the ultrasound probe in the supraclavicular fossa, and the tip is you need to tilt slightly inferiorly the probe. You need to tilt the probe slightly inferiorly to visualize the subclavian artery in the transverse view and the brachial plexus just posterior to the subclavian artery. Sometimes you need to rotate the probe in order to get a better view of the brachial plexus. So in this level also, there will be sometimes in certain patients there will be arteries surrounding it. Well, as I was saying, for this at this level also sometimes there will be arteries present, mainly the dorsal scapular artery again, transcervical artery and suprascapular artery. So this is an ultrasound image of the brachial plexus at the supraclavicular fossa. As you can see, the dorsal scapular artery coming up from the subclavian artery, just superficial to the brachial plexus, making the block very difficult. And this is another ultrasound image showing the suprascapular artery coming out from the subclavian artery, crossing the brachial plexus. So how you conduct the block? So confirm the landmarks. The aseptic technique again, infiltrate the skin, and we usually advocate a lateral to medial approach. Even though there is also a medial to lateral approach, we usually conduct this block in the lateral to medial approach. And we insert the needle into the sheath. And when you are inserting the needle into the sheath, you often feel a pop. So the first injection should be directed towards the space, towards the junction between the subclavian artery and the first rib. We call this the corner pocket. We directing the needle towards the rib is actually safer and avoid the pneumothorax. So at this corner pocket, usually we inject about 10 mL of local anesthetic in small aliquots. The aim is to float the brachial plexus superficially. After the corner pocket, we usually redirect the needle towards the superficial aspect of the plexus. So the whole objective of this is to have the brachial plexus surrounded by local anesthetic. So this is a ultrasound image to illustrate the block. So the needle first injection will be at the corner pocket, and the second injection will be superficial. So notice that actually you must infiltrate your LA in the sheath that contain the brachial plexus, and the aim is to surround the brachial plexus with local anesthetic. So the volume that we use for supraclavicular block can vary between 20 mL to 30 mL. Then for the concentration is the same. So complications, the usual complication also, we can have nerve injury, hematoma, pneumothorax, okay, thank you. Right.
Thank you very much, Dr. Ng, for the informative talk. Now, to put it all together, we will have a demonstration of the two blocks. The two blocks that will be demoed will be the supraclavicular block, and the second block will be the interscalene block. Our demonstrators will be Dr. Khairul and Dr. Nabila. Welcome, Dr. Khairul and Dr. Nabila.
Assalamualaikum and a very good morning. In this video, we will show you how to perform supraclavicular block for shoulder trauma. This block can be performed with the patient in supine, semi-sitting or slight lateral position with the patient's head turned away from the side to be blocked. Place a high-frequency linear transducer superior to the clavicle at the midpoint and parallel to the neck. To achieve the best possible view, the transducer must be tilted slightly inferiorly. The goal is to see the subclavian artery in the transverse view and the brachial plexus posterolateral to the subclavian subclavian artery. The first structure we need to identify is the subclavian artery. Subclavian artery is readily apparent as an anechoic round structure. This is the sonoanatomy that we need to identify. The brachial plexus can be seen as a bundle hypoechoic round nodules just posterior and superficial to the artery. We also need to identify pleura and first rib. These structures are linear hyperechoic structure immediately lateral and deep to the subclavian artery. We also need to identify middle scalenus muscle on the lateral side. Some describe the brachial plexus structure as a bunch of grapes. We are using Stimoplex 360 50mm needle using in-plane approach. To visualize the brachial plexus, the transducer is oriented in the sagittal plane until the first rib is seen deep to the plexus and the artery. So we aim first to deposit the LA at the inferior trunk of the brachial plexus. For analgesia, we are going to give ropivacaine 0.2%, 10 mils at this inferior trunk of the brachial plexus. We aspirate. Once there is no blood and clear, we inject the LA. So once we have created a space, then we push in our needle at the pocket of the brachial plexus. Next, after we deposit the local anesthetic, 10 mils, we flatten our needle, and the next aim would be the superior trunk of the brachial plexus. Once we feel a pop, then once again we aspirate and make sure there is no blood. We inject about another 10 mils of ropivacaine 0.2%. So total there will be 20 mils of volume. So this is the spread of the LA, and you can see the brachial plexus is flooded with the LA. Thank you.
Assalamualaikum and hi, I'm Nabila. Let's talk about interscalene block. So first of all, patient should be in a supine position with head slightly elevated and turned away from the operator. Patient's neck and upper chest need to be exposed, cleaned and draped prior block. So the most important landmarks here are the clavicle and the sternocleidomastoid muscle. High frequency linear probe is then placed transversely at the supraclavicular fossa. Brachial plexus is identified, and then the probe is moved cranially until the grape-like brachial plexus change to a traffic-like appearance. Most of the time, the final probe position is at the middle of the neck, slightly posterior to the sternocleidomastoid muscle. Then, using an in-plane approach from the posterior end of the probe, the needle is inserted, aiming towards C5 and C6 roots. Well, it is not advisable to insert the needle in an antero-posterior manner, as the phrenic nerve lies in between the sternocleidomastoid and the anterior scalenus muscle. Now let me highlight the important structure that we need to identify when performing an interscalene block. Well, this is an ideal sonoanatomy. It shows that the brachial plexus, more specifically the C5 to C7 roots, are being sandwiched between the anterior scalenus muscle and the middle scalenus muscle. So moving medially, the vertebral artery can be seen lying deep to the anterior scalenus muscle. Another important structure that we need to take note is the dorsal scapular nerve, which lies in the middle scalenus muscle. So the linear arrangement of the C5 to C7 roots reminds us of a traffic light or even a butterfly, with the wings represented by the scalenus muscles and the brachial plexus is depicted by the body. So now let's move on to the exciting part, which is the needling part. This is a superficial block, so the needle length shouldn't be more than 80 millimeter. So the needle block is slowly being advanced towards the brachial plexus, piercing through the middle scalenus muscle and then the nerve sheath. So the needle tip is placed between the C5 and C6 roots. LA is injected in a small volume, maybe roughly around 1 to 2 mL after negative aspiration. And we can see that the LA is enveloping the C6 roots. The needle is readjusted, so the LA distributed to C5 as well. So during the needling part, it is very important to ask the patient if he or she experience any pain during the LA injection. Patient might feel pain if the LA is being injected intraneurally. Post-procedure, the things that we need to observe are the common complications that can occur in an Interscalene block, like hemodynamically instability if, let's say, we inject LA inside the intrathecal or epidural, dyspnea if we block the phrenic nerve, even Horner syndrome if we accidentally block the stellate ganglion. A recurrent pharyngeal nerve blockade can happen, which gives rise to a hoarseness of voice. And lastly is the last, which is the local anesthesia systemic toxicity. So that's gist about the interscalene block. That's all for now. Till we meet again. Thank you.
Thank you very much, Dr. Nabila. So now, without any further delays, I would like to invite Dr. Sabri for the lecture on hip trauma. Welcome, Dr. Sabri.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning to everybody, all the specialists and fellow friends and also participants. Thank you for the committee that invited me to this virtual regional anesthesia workshop of EDHKL. And today I would like to share about this hip trauma, how we can use, we offer the multimodal analgesia to counter the pain of hip trauma patient by using our PENG block and Fascia Iliaca in compartmental block. So today I would like to talk about the innovation to the hip joint, the block technique for both of the FICB and PENG, and comparison of both also. So first of all, the indication of the FICB and PENG block very various. That I can say first for analgesia for hip trauma and fractures, either patient will go to arthroscopy surgery or convert to arthroplasty, and also analgesia before mobilizing the patient, either mobilize the patient from ED to the ward, or from before we put the patient either epidural or spinal anesthesia in the operation theatre. Also, this FICB and PENG block can use for to tackle cancer pain management or chronic hip pain, and also can give for the hip dislocation patient, and can as so-called anesthesia for medial thigh and vein ligation surgery or stripping of varicose vein surgery, which the extended volume 30 to 40 mL of half maximum concentration dose for anesthesia. So-called, like if we use ropivacaine, we can use about 0.375%, or we use the chirocaine or levobuvacaine, we can use 0.25%. So this is the anatomy. The body structure of the hip joint. The most important is our axis, anterior superior iliac spine from the iliac bone. Coming to the anterior inferior iliac spine, coming down to the iliopubic eminence and pubic rami. and also this obturator foramen. This schematic of lumbar plexus and lumbar sacral plexus, very messy, right? So actually, this is on the background of the psoas muscles, and then the iliacus muscle, and also piriformis muscles. So this lumbosacral is not so messy like the brachial plexus just now. From the root of the lumbar and sacral spinal nerve, they will divide into the branches, terminal branches. They not distinguish the truncal, the cord, or the division like the brachial plexus. So from the anterior and posterior division just now, okay, for the anterior division of lumbar plexus, they give rise to the iliohypogastric nerve and ilioinguinal nerve, also genitofemoral nerve, and the last one is obturator nerve, whereby the posterior division of the lumbar plexus will give off the femoral cutaneous, the most lateral side, and then the femoral nerve as well. For the sacral plexus, the anterior division will give rise to this sciatic nerve of the tibial component, and then the pudendal nerve, and then the posterior femoral cutaneous nerve. And the last one is the posterior division of sacral nerve, will give rise to the perennial component of the sciatic nerve, and then the piriformis nerve. Okay, so the innervation, if we can divide into anterior and posterior of the hip joint, the anterior part is nociceptive component, which is innervated by femoral nerve, obturator nerve, and accessories obturator nerve, whereby the posterior side from the sacral plexus is a proprioceptive component from nerve to the quadratus lumborum, superior gluteal nerve, and muscular articular nerve. And then we talk further from the anterior point of view. They divide into superior, inferior, medial, and lateral. So they divide into 4 quadrants, which is the most nerve lies at the inferior lateral quadrant, which is femoral and obturator, and also inferior medial quadrant, innervated by femoral, obturator, and accessory obturator nerve. Okay, so this very crucial, means very important structure when we perform the fascia iliaca and also PENG block. When we position our probe at beside the axis or femoral inguinal ligament, so we can view from superficial to deep structure. After the soft tissue, we can reach the fascia lata. Below that is fascia iliaca, and then below the fascia iliaca comes our femoral nerve, femoral artery, and femoral vein, superficial to the psoas and iliacus muscles. And below that is our articulate branches of femoral nerve, where inside the psoas muscles, and this also medial of that got accessories obturator nerve, and more medial we can get the obturator nerve. So they did the anatomy study of innervation of the interior hip capsule. So they dissect the 13 hemifabric cadaver, and then what they found out is the hip joint innervation. The anterior capsule, primary by the femoral nerve, obturator and accessory obturator nerve, and secondary, the small muscle is by the nerve to the psoas and nerve to the rectus femoris. Oh, everybody boring, is it? Okay, and then the posterior capsule, the primary is innervation by the superior gluteal nerve and inferior gluteal nerve, and also sciatic nerve. And secondary means that the muscle component is nerve to quadratus femoris, either posterior medial, posterior superior, and posterior inferior. Okay, so we come to the more interesting part, how to block to do block. The first one is fascia iliaca compartmental block. So actually, fascia iliaca compartmental block or FICB is principally is a extension of the femoral nerve block. In different of actually we give more volume. If we give 20 mils for femoral nerve, for this FICB, we extend the volume to 30 to 40 mils of half maximum concentration, as what we mentioned before. And then using the needle about 50 mm, this block can cover for femoral, lateral femoral cutaneous, and or can cover obturator nerve. So previously, this FICB also known as 3-in-1 block. So they said this block is good analgesia associated with hip pathology, either fracture or pre or post operation pain management, and then can use a various approach. Either we can use landmark technique, infra-inguinal or supra-inguinal. First, I will talk about this landmark technique first. So how to do this landmark technique? We draw a imaginary line from the pubic tubercle and assist. We divide into 3 divisions. The 1/3 from 1/3 lateral, 1 centimeter below. This is the injection point of the landmark technique of FICB. So we can inject about 30 to 40 mils of our local anesthetic agent, and then make sure this local will spread laterally to cover this lateral femoral cutaneous nerve, and medially to cover femoral nerve. And if we are lucky, the LA will spread beyond the pectineus muscle to cover the obturator nerve. So now we go to the other approach, which is suprainguinal caudocephalic approach. They divide into 2 technique, which is one dual view iliacus plane technique. Okay, so same as when we scan to do the femoral nerve, position our probe at the before this we know that got Mickey Mouse point and then the snowman point. So for this we use the snowman point, and then from the femoral nerve, just slide the probe laterally until we reach the most, the iliacus muscle is the most superficial. And then after that, we mark with the finger here, the middle point of the transducer, and then rotate the probe horizontally to the axis. Imagine that these fingers is the injection point of our needle letter. So this is a dual view iliacus plane technique. And then the other one is FICB, which is suprainguinal caudocephalic approach. And then this is a direct longitudinal axis technique. How we did? First, recognize our axis. Oh, sorry. Should be here. Okay, should be this axis, and then just place one finger medial to the axis, and then position again our probe just medially to the finger, and then we aim the caudal end of this transducer at the inguinal ligament. Okay, and then at this point we can view the sonoanatomy, which is we can view the anterior inferior iliac spine, and then this is our fascia iliaca actually. Okay, so give about 30 to 40 mils of injection, and make sure our needle comes from caudal to cephal, and then make sure we can see this dorsal circumflex iliac artery, and then when you give our local anesthetic drugs, make sure that this artery is not compressing down. Okay, and then we need to make sure that our local spread downwards here to cover the pelvic area. So that's when we give the local will spread like this. Okay. the local we need to make sure they're spread laterally and proximally. So this is the last technique approach of the infrainguinal lateral to medial approach of FICB. So position the patient same like we want to do the femoral nerve block, but slide the probe a bit lateral towards the axis, and then give the injection from lateral to medial in plane technique with the same needle and the same concentration and dose of local anesthetic drugs. So like this, from this is femoral nerve, scan lateral side, and then we can see this fascia iliaca here. And then after give the local anesthetic agent, make sure that the local is spread laterally below these serratus muscles. And then this can cover the femoral nerve, lateral cutaneous nerve here. Okay, so we go to the last block that I will share today is a pericapsular nerve group or PENG block. Okay, so this is a quite new technique described by Drs. Philip Peng, Laura Giron-Erengo, Ku Jingqing, and Richard Bruhl and Anahi Perals in 2018. Only about 2 years plus age of this block. They said the hip fracture patient is a common orthopedic emergency in elderly especially, and then with significant morbidity and mortality rate. And then our popular regional anesthesia analgesic strategy so far, so-called we use femoral nerve block, fascia iliaca block, or femoral 3-in-1 block. The effect is not so good. The analgesic cover is only moderate, and then some literature said obturator nerve always not covered. So they said actually the anterior hip capsule is innervated by mainly the femoral nerve, obturator nerve, and accessory obturator nerve. And then this anterior capsule is most rich innervated part of the hip joint. So this nerve should be the main target actually for this hip analgesia. And they said also the high articular branches from femoral nerve, accessories obturator nerve are consistently found between the AIIS and iliopubic eminence. Because of this info, so they come out this upper ultrasound guided technique for blockade of these articular branches to the hip. So this comes the PENG block. Okay. So actually PENG block is a interfacial block, targets the articular branches, the accessory part of the femoral nerve, obturator nerve, and also the accessories obturator nerve between the AIIS and iliopubic eminence. So with this technique, potential matter sparing effect is very good. So means we don't have the motor block, and then patient can get early ambulation, and then surgeon also like. They did study a case series of 5 patients with hip fracture, and then pain score is very good. Okay, all patients with significant reduced pain score and no quadriceps weakness. So this they are published in brief technical report in 2018. So they said very good. All the 5 patients after 30 minutes the pain reduced from 10 to 2 and at least from 7 to 3. It's very good block described by them. So how to do this block? Position the patient supine, and then with the either curvilinear probe or linear probe with high frequency probe, position the probe at the horizontal of the axis. Okay, over the axis, and then align the probe. Okay, counterclockwise rotate 45 degrees towards the pubic ramus. Okay, and then from this, slide the probe medially towards the pubic rami. Okay, at this imaginary line, and then at this point we can see our iliacus muscles, psoas muscles. psoas tendon, our femoral artery, our femoral vein, our iliopubic eminence, and maybe we can see this pectineus muscle as well. Okay, and then at this point we can inject from lateral to medial. Can use about 80 to 100 mm needles, also with the same volume of local anesthetic, also same concentration, about 30 to 40 mils. And then we inject, observe the LA will cover below this psoas tendon and just above the pubic rami. Okay. And then after we give the LA, make sure the LA is spread here also. And then if patient either big size, muscular, or maybe obese, we can use the curvilinear probe to see more structure. And then maybe we need a higher and longer needle as well. And then make sure the local is spread beyond this psoas tendon. Okay, so this is a comparison in between FICB and PENG block. You can choose either one. FICB is older block. PENG is young block. Okay. With FICB, maybe the operator nerve will spare. So the pain may be moderate reduction in pain, but with PENG block, the lateral femoral cutaneous nerve will spare also. So, but better pain reduction of the hip trauma patient. And then with FICB, we can maybe get the motor block because they block the femoral nerve directly. But the PENG block, the motor sparing effect is good. So patient can early mobilization. And they said PENG block is faster onset. So the choice is at your hand. With that, I would like to say thank you.
Thank you very much, Dr. Sabri, for the enlightening talk. Before we proceed to the demo, we will have a few minutes break for the viewers at home to stretch your legs, have some coffee. We'll be putting up a video and the QR code will be followed by that. Just keep your speakers on and I'll make some announcement before we proceed to the next demo. Thank you.
Assalamualaikum and a very good morning. In this video, we will show you how to perform Fascia Iliaca compartment block as an analgesic modality for hip trauma. There are two approaches for this block. The first one is infrainguinal, lateral to medial approach, and the second one is suprainguinal, caudal-cephalate approach. In this video, we will show you suprainguinal approach with direct longitudinal axis technique. Patient in supine position. First, we identify anterior superior iliac spine laterally. Place an index finger immediately medial to the axis. Align a high frequency linear transducer immediately next to this finger with the caudal end of transducer just above the inguinal ligament. Alignment of this transducer should be superior medial to inferior lateral from cranial to caudal. We are using Stimuplex Ultra 360 80mm needle using in-plane approach. Here the needle already pierces the first fascia, which is fascia lata. Now the needle is approaching fascia iliaca. This is the sonoanatomy that we need to identify. The most superficial fascia is fascia lata. Just beneath this is fascia iliaca. DCIA, deep circumflex iliac artery, lies above fascia iliaca and iliacus muscle lies below it. two muscles you need to identify are the internal oblique and sartorius muscles at the both ends. Ilium is identified as rounded, hyperechoic rim with hypoechoic shadow below it. Some describe this as bow tie sign. Both ends of the bow tie represents the muscle. On the capillate side is internal oblique, and on the caudate side is the sartorius. So here we can see that the needle already pierced the fascia lata, which is the first fascia. Now the needle is just above the fascia iliaca. Once we feel a pop, then we are sure that we are in the fascia iliaca compartment. Once we are here, we aspirate and make sure there is no blood. If it's clear, we are going to inject our LA. We are using ropivacaine 0.2%, 20 mils of volume. We can use up to 40 mils as long as it does not exceed the toxic dose. So here we are going to inject our LA. As you can see, the LA spreads very nicely towards cranially, and if the spread more cranially, then there is possibilities it will spread to the lumbar plexus. Okay, so there is some space created by the LA, so we are going to dive in a little bit our needle and we inject some more LA into that space. So now we are going to check the spread of our LA. We put back our transducer along the inguinal ligament and we identify the femoral vessels, femoral nerves, and the fascia iliaca. So the LA, there is some LA in the compartment. So thank you. Assalamualaikum and hi. PENG stands for Pericapsular Nerve Group. It was first introduced in late 2018 by a group of regionalists primarily from Canada. It is an interfacial plain block aiming to block articular branches supplied by femoral, obturator and accessory obturator nerve. It is an easy regional technique to perform in supine position with motor sparing benefit. It targets only the sensory branches and not the posterior mechanoreceptor. It involves deposition of LA in the musculofacial plane between psoas muscle and the superior pubic ramus. There are two approaches to perform PENG block. First approach is using low frequency curvilinear transducer over the anterior inferior iliac spine in the transverse plane towards pubic symphysis. Second approach is using high frequency linear transducer along the inguinal ligament. In this video, we will show you the second approach. Transducer is moved cranially about 1 to 2 cm above inguinal ligament to visualize femoral vessels, femoral nerve, anterior inferior iliac spine, psoas muscle, psoas tendon, and iliopubic eminence. Some describe the appearance of anterior inferior iliac spine and iliopubic eminence like a spoon. We call it as spoon sign. We have the head of the spoon and the tail of the spoon. This is the iliopubic eminence and this is the anterior inferior iliac spine. The pubic tendon lies above the head of the spoon. Once identified, we can inject lignocaine 2% to numb the skin. We are using Stimuplex Ultra 360 100 mm using implant lateral to medial approach. To avoid hitting anterior inferior iliac spine, adjust the needle by decrease the angulation, which then takes the needle away from the target towards the superior pubic ramus. We also can purposely advance the needle and hitting the iliopubic eminence. Then we draw our needle by 1 to 2 mm. Deposit our local anesthetic between pubic tendon anteriorly and pubic ramus posteriorly. We inject ropivacaine 0.2%, 20 to 40 mL in this plane. Ideally, LA should track medially beyond the iliopubic eminence in order to block the obturator nerve and accessory obturator nerve, which are more medial. Pubic tendon will then appear floating above iliopubic eminence. For optimal hip trauma analgesia, we suggest to combine PENG with lateral femoral cutaneous block. Just to remind, an upward tracking of LA will indefinitely cause a motor blockade due to possible blockade of femoral nerve. Thank you.
Thank you very much, Dr. Khairul. Before I proceed to sharing the screen for chest trauma, which will be given by Dr. Nabila, there's a reminder, please do ask questions in the chat box. I know for many of the viewers, this will be a very new thing, so do not be afraid that the questions are too basic. It will benefit all of the participants. So after the chest trauma, we will have the Q&A session, so you have plenty of time to ask regarding anything. Okay, without any further delays, I welcome Dr. Nabila to give her talk.
Hi, Assalamualaikum and good morning everyone. So I was given a task to talk about regional anesthesia for chest trauma. So I will only emphasize on two blocks, which is the Serratus anterior plane block and also Erector spinal plane block. This would be the outline of my presentation today. So let's start off with the first block first. The Serratus anterior plane block was introduced by Blanco in 2013. Initially, it was introduced to give analgesia for breast surgery, but then because of the spread of the block, they noticed that it is also good for rib fracture. So to know more about it, we have to have at least a basic understanding about the chest wall innervation. So we know that the spinal cord divide into the dorsal rami and also the ventral rami. The ventral rami travel along the chest, becoming the lateral cutaneous branch here, which branch off at the mid-axillary line, divide it into the posterior division and also the anterior division. And the intercostal nerve, which is the ventral rami, will travel anteriorly towards in front before giving off a anterior cutaneous branch. So for this Serratus anterior plane block, the aim of the block is here. This is the plane that we are giving the block at. So primarily, it only blocks the lateral cutaneous branch. So the spread of the block is like this, sparing the dorsal rami and also the anterior cutaneous branch. So by knowing how does it spread, it helps us to know what kind of cases that's suitable for the Serratus anterior plane block. So this is the anatomically how does it spread. So we can see that anterior portion, it only spread until the axillary part and also a bit of the chest and behind. So this is how the patient should be placed on during the Serratus anterior plane block. Operator, patients, and the ultrasound machine should be in a straight line. And patients is in a supine position. The head can be elevated a bit so that patient can be less in respiratory distress, the probe is placed at the axilla region. Or more specifically, we place the probe transversely at the mid-axillary line and scan posteriorly until we see this kind of a sonoanatomy. So the sonoanatomy that we are looking at is the latissimus dorsi, the serratus anterior, the ribs. Most likely this is the fifth ribs, correspond to the nipple level, and also the pleura, which we can see sliding on top. So for the needling part, well, the length of the needle is depend on the scalp scan basically. For this patient, the depth is only around 2.5 centimeter maybe. So the needle length maybe should be less than 50 millimeter. But if you have a bigger size of patient, we can get a longer needle. So we insert the needle in plain manner, aiming towards the ribs in order to avoid any kind of pleural structure puncture, and then deposit the LA on top of the rib. This is the deep SFP block. We can also place our LA superficially, meaning that we're aiming our needle superficial to the serratus anterior muscle and deposit our LA superficially. So how much should we use? Basically, this is a fascia plane block, so we aim for an adequate volume. The volume plays a bigger role here. So at least 20 to 40 mils indicated for this kind of blocks, and we would prefer for a long-acting local anesthetic so that it can last at least for a day. And how about the concentration? We calculate first the maximum recommended dose for the patient, and then from there we see how much is the volume that can the patient accept. Okay, what are the complications from the serratus anterior plane block? There's this one artery that we have to watch out for this block, which is the thoracodorsal artery. It is between the latissimus dorsi and serratus anterior plane block. So we have to make sure that our needle doesn't inject there in order to avoid any kind of hematoma or intraarterial injection. Other than that, the pneumothorax is the risk as well, and infection. Now let's move on to erector spinal plane block. So erector spinal plane block basically was introduced in 2016. It is started off as a treatment for thoracic pain, like for a chronic pain kind of thing. But then we noticed that it was also useful for a surgery and also for a rib trauma. So where does we put our LA in this kind of block is deep to the erector spinal muscle and also superficial to the transverse process. So that is basically the diagram shows us where we block, and basically because putting a LA there, the LA diffuse, blocking the dorsal rami and also the ventral rami. And in addition, when we already put the LA there, it can also block all the branches up until in front, giving a sufficient block hemithorax. So this is the spread of the block. As compared to the serratus anterior plane block, it only blocks half of the anterior and posterior and also axillary part. Erector spinal plane block can confidently block at least 2 levels from the injection point. Hemithorax, meaning that half of the chest wall. Okay. Patient can be put in several positions for this block. This is the lateral position. Make sure that patient is comfortable, and again, the operator, the patients, and the ultrasound scan should be in a straight line. And then patient can be put in sitting position. Most of the time, I think the trauma patient would be more comfortable in a sitting position. Less movement is needed for them. And then if the patients are quite comfortable to put in prone, we can put them in prone. In terms of proning the patient might feel a little bit uncomfortable, but for us, the operator, it is the most suitable position because it's easy for us to slide the probe lateral up and down rather than against the gravity that we have to slide up and down. Okay. So for erector spinal plane block, the first thing that we need to know is that we need to palpate the spinous process here. And then slowly move the probe a bit lateral, slowly, roughly maybe around 2 to 3 centimeter, we will get this kind of view. So this is what we are looking at. The transverse process here look like a square acoustic shadow. And then we have all these 3 important muscle layers here, the trapezius, rhomboid, and erector spinae muscle. And we can see the rhomboid muscle tapered off. And it usually ends at T5. So this most likely correspond to the T4, and here would be correspond to the T5. So what kind of needle that we can use for this block? It also the same thing as the serratus anterior plane block. We have to see the depth of the scan. For this patient also, I think 50 millimeter is sufficient, but if we have a bigger size patient, 80 to 100, we might need to use a longer needle then. But let's say if we move the probe a bit more lateral, we might get this kind of view, which is not the optimum view because we are aiming for the transverse process, not the ribs. The ribs looks like more a rounded shape here, and we can see the pleura with the same kind of depth. Okay. So if we kind of like get this kind of view, we just slide the probe medially a bit to get back this view. And the needle is inserted in inclined manner as well, aiming towards the transverse process. Sometimes some people like to hit the transverse process and then we draw a bit before injecting the LA. And then this is the LA spread that we are looking at. It should spread carefully and cordedly. Okay, and then we can see a pumping effect, meaning that when we inject the LA, the space will be open up, but when we didn't inject the LA, the space will shrink back, and that happens every time we keep pumping in the LA. So this is also a fascial plane block as well, so we need a large volume. The minimum volume is the 20 mils. This is just a rough idea for us how much to give for a rib trauma. So this table is based on 49 cases that was done by Ludwig et al. They give this kind of block to a 49 patient and look at the pain score. So it can be divided into the unilateral and bilateral. So we can see that the most important part here is that we don't exceed the maximum LA dose. And then from there, we can just know that the minimum that we need to use is 20 mil. Okay. So the ESP block, the erector spinal plane block, is actually very far away from the central structure. So very rare for us to have any kind of complications. But then again, when counseling patients, we still need to highlight this few of the complications that might happen to them. Okay, these are my references. So what's next? Now we have to have a determination and start doing it. Keep the excitement ongoing, and then be patient. Don't get disappointed with any kind of setbacks. And then nevertheless, the patient safety is our top priority. And lastly, practice, practice, and practice. With that, I thank you.
Thank you very much, Dr. Nabila, for the talk and the kata-kata semangat at the end. We will proceed next to the demos of the serratus plane block and erector spinae block. After this, there will be a live Q&A session, but before that, we will have a bit of a break. So you still have a chance to ask your questions. Keep them coming. And now we will proceed back to, I'll pass the screen back to Dr. Cairo.
Assalamualaikum and hi guys. Now let's focus on how to perform serratus plane block. There are two types of serratus plane block, superficial and deep. In this video, we will show you how to perform deep serratus plane block. This block can be performed with the patient in lateral or supine position. It is performed in the axillary region and a more lateral and posterior location than the PEX 1 and 2 blocks. High frequency linear transducer is typically used for this block. Two main methods in identifying the plan for the serratus plan block. The first method requires counting the ribs from the clavicle while moving the transducer laterally and distally until the fourth and fifth ribs are identified. The transducer is orientated in the coronal plane and then tilted posteriorly until the latimus dorsi is identified. As for the second method, which we use in this video, the transducer is placed across the axilla where the latimus dorsi appears more lateral. The location of the thoracodorsal artery is easier to identify this way. After patient is cleaned and draped, transducer is placed using the second method. The two main anatomy landmarks need to be identified are the latimus dorsi and serratus anterior muscle. The thoracodorsal artery runs in the facial plane between these two muscles. The ribs, pleura, and intercostal muscles can also be seen during the procedure. Now we move to the interesting part, the needling. We are using Stimuplex Ultra 360 80mm needle in plane anterior to posterior approach. The needle now is in this anterior serratus anterior muscle just above the rib. Note that if you want to perform superficial serratus plan block, the tip of our needle should be in between the latimus dorsi and serratus anterior muscle. Once we feel a pop, aspirate to make sure there is no blood, then we can inject our LA. For the sonor anatomy that we are looking for is the latimus dorsi and the serratus anterior muscle. The serratus muscle is identified as a thick hyperechoic muscle deep to the latimus dorsi and is imaged over the ribs. Ribs can be identified as a rounded shape hyperechoic rim with hypoechoic shadow beneath it. Pleura can be identified as a line with shimmering appearance. We inject ropivacaine 0.2% 20 mL in the plane. We can see the serratus plane has been lifted up. Just to remind again, this is an interfacial plane block. Volume is more important than the concentration. At least 20 mL of LA need to be deposited in the plane. For chest trauma, this block produces analgesia for the hemithorax, anterior and laterally. For posterior rib fracture, it is advisable to perform ESP rather than serratus plan block. Serratus plan block also can be used as analgesia for upper abdominal dermatomes. We need to perform this block at the more distal ribs to produce such effects. So, here we can see the spread of our LA along the plane. Thank you. Assalamualaikum and a very good morning. Now we are going to show you how to perform Erector Spinae plane block. The ESP block is relatively new interfacial block technique introduced in 2016 by Ferrero et al. The aim of the block is to get a spread of LA in the potential space in between the erector spinae muscles and transverse process, which is near the costotransverse foramen. This will result in spread of LA longitudinally to the ventral and dorsal rami of the spinal nerve. This block can be performed with the patient in sitting position, lateral decubitus, or prone. In this video, the patient is in sitting position with her back towards the operator. Note that the ultrasound machine is placed on the opposite side in front of the patient. This is to create an ergonomic environment for the performance of this block. High-frequency linear transducer is typically used for this block. To identify thoracic level, we can use anatomical bony landmarks. Spine of scapula corresponds to T3 and inferior angle of scapula corresponds to T7. We can also determine the vertebral level by doing rib count scanning. The sonoanatomy, we are looking for the 3 layers of muscles and at the upper back: trapezius, rhomboid, and erector spinae lying on the top of transverse process. Note that rhomboid muscles end at T5 level. This is another way of confirming the correct level of target for this block. You need to differentiate ribs and transverse process. Rib is more rounded shape and transverse process is square shape. After thoracic level is identified, the transducer is placed in paramedian sagittal orientations looking for the tip of transverse process of that level. Now, we are going to inject our needle using Stimuplex Ultra 360 100mm implant capillate to caudate approach. Our needle is now at the erector spinae muscles reaching to the ESP. Once we feel a pop, we are convinced that the tip of the needle is in the plane. Aspirate and make sure there is no blood and clear. We inject ropivacaine 0.2% at least 20 mL and we aspirate every each mL of LA given. Once we inject the LA, the plane will expand and collapse after we finish injecting. This is what we call as pumping effect. This block is quite safe compared to paravertebral block as the pleura is far away from the plane. Risk of pneumothorax is minimal. You also can advance your needle until you reach the tip of transverse process and then withdraw by 1 to 2 mm to ensure you are in the correct plane. This block produces multi-dermatomal analgesia for the trunk, anterior, lateral, and posterior. From previous study and case reports, coverage of 4 to 5 dermatomal level up and down, the level of injection is usually produced with 20 to 30 mL of LA, although the spread can be variable. This is to show you the spread of LA. Next, we want to check the spread of our LA. Move the transducer carefully until the spread ends and then move caudally. Thank you.
Thank you very much, Dr. Khairul, for all the demos today. Finally, we'll be having a Q&A session, but we will be having a bit of a break, 5-minute break. We have compiled a list of questions from the chat box, but if you do still have any burning questions, do type in and we'll try to accommodate them. It will not be a live interaction between the home audience and the panelists, so all questions have to be submitted through the chat box. Continue to mute your mics, but keep on your speakers. I'll make an announcement when we come back in 5 minutes. See you soon. Okay, welcome back. We are now at the final part of our webinar, which is the live Q&A session. We have two panelists with us, Dr. Azrin and Dr. Amir. We will allocate about half an hour for this session. Okay, without any further ado, we will start the Q&A session. So we'll start the first question, and I'll address this to Dr. Azrin. First question comes from Dr. Gopinath of EDHL. How do we calculate for the toxic dose of LA?
Okay, to answer the question, basically we have to go back to our pharmacology days and look for the maximum available toxic dose. For the common drugs that we use, for ropivacaine, it is 3 milligrams per kilogram. And for levobutalmine, you can go up to 2.5 milligrams per kilogram. Bearing in mind that most of the blocks that we discussed today are plain blocks, and volume is an important part. So because of that, we need to balance out the mass of drugs being used by tailoring the concentration and also the volume. But for most of the blocks, the minimum volume is about 20 mils, except for interscalene block, which is 5 to 10. So based on that, if we have an average adult 20 mils is sufficient for the various blocks that we've discussed. And for analgesic doses, usually we go up to 0.375 for Ropi and also 0.25 for Levo. So basically, if you go by that, 20 mils of half of the maximum doses should still be safe.
Can I add something on this issue? The manufacturer only recommends the recommended maximal dose, which is depends on the type of the local anesthetic. The recommended maximal dose is there to prevent the concentration after we inject into the body, to prevent the plasma concentration become toxic. Okay? But I have to warn you, any concentration, if you accidentally inject into the intravascular, can lead into local anesthetic systemic toxicity. That's what I want to emphasize on this issue.
Alright, thank you very much. We will proceed to the next question. It comes from Dr. Hasnita from EDHL as well. How do we dilute and prepare the LA? I'll address this to Dr. Amir.
I think this question is also related to the previous question. First, to calculate the maximal dose, you have to know or estimate the weight of the patient. Okay, and after taking in consideration the maximum recommended dose, you have to decide how much volume you want to use. Let's say my weight is 80 kilogram, and I'm going to use a local anesthetic that the maximum recommended dose is 2 milligram per kilogram. So I wouldn't exceed 80 times 2 is 160 milligram for that particular local anesthetic. So, and if I need volume of 40 mils, example for Fascia Iliaca compartment block, so I have to decide. Let's say the preparation of the local anesthetic comes in 0.5%, which is 5 milligram per mil. So, so you have to dilute or further the local anesthetic to reach the volume that you want, which is 40 mils. So example, I would quote, let's say we take an example of levobutalmine, which is 2 milligram per kilogram. It comes in 10 mils of ampule, which is 50 milligram. So if you want to use 3 ampules of which is 150 milligram, so you are still safe, but you need another 10 mils to add into the total local anesthetic to make up into 40 mils, if you can get what I mean. Okay? So the final concentration will be slightly less than the 0.5%. Okay? So how to dilute it? I would recommend it to be diluted in a sterile manner. Use normal saline as the diluent to get the final volume.
Okay, thank you very much. This next question, I think would be interesting to get input from both panelists. It comes from Dr. Khalil from EDHKL. What challenges do you foresee in instituting RA in the emergency department?
I think this is an organizational question. It actually depends on what is the available setup that you have in your hospital. If you have an already established regional anesthesia team in your hospital, then probably you can get them to be actively involved to help you set up a center or facility for RA in your ED. So I think there's a few things that we have to look at: the equipment, the drugs, the facility, the training, and how to set up. I think these are some issues that we had to go through when we first set up. So I think it needs a bit of input from the anesthesia department, and also the administration within the ED itself, and also probably a bit of help from top, from the NARA to help out. So those are the initial few steps, but once we actually have instructed to manage to get that into place, then the rest is to getting your anesthetic colleagues to help out, to look at how they set up the organizational aspects around it, and what are the guidelines that you have to set up. So those are the things that that needs to be considered. So I guess for the initial step, it will probably be a bit tough, but once you get the first few steps in place, then probably it's going to be helpful later on. But the most important thing is to have a core group of people within that setup to have the same interest, and to get start off with this the initial few stages. So I guess those are the things that you have to figure out how to overcome: equipment, drugs, training, input from other colleagues. So I guess that's the biggest challenge to start off in any setting.
I share common thoughts on this with Dr. Azrin. The core business of emergency department is, I know it's resuscitation, but I would like to share my personal experience. I had the opportunity to be admitted to yellow zone for a fracture forearm. I think it was a busy night. The yellow zone was like, I think, chaotic. There's no penjarakan social at all, I think, because it's very close. I think they need more space for a busy day. But I was in severe pain. Okay, 50 milligram tramadol did nothing to me, and I had to go for X-ray to get the AP and lateral view. I just couldn't imagine the severe pain that I had. So I think besides resuscitation of patient, I reckon ED doctors has also to look into effective pain relief for the patient. Of course, resuscitation comes first, but I mean, pain relief is also another humane thing to look into. So in that situation, busy situation, I know the setback or drawbacks of the this is actually a good organization issue, but you need a lot of effort, conjoined effort from from other department as well to tackle this issue. So, but this is actually the first baby step by organizing this workshop towards a very long journey.
Okay, thank you very much. I think what both doctors have said resonates with us in ED, the RA team here. I will keep the advice in mind, definitely as we work closely together. We'll move on to the next question from Dr. Shankar, HRPB ED Ipoh. He would like to ask the panel on the opinion in giving intra-articular shoulder injection with lidocaine for shoulder dislocation. Maybe Dr. Azrin would like to pick this up.
Honestly, we don't have any experience using intra-articular injections, and most of the patients for shoulder dislocation would not come up to OT for procedures. So I guess what I'll be answering is based on typical considerations. So basically, for intra-articular injection with lignocaine, we know that there are pain receptors within the capsule and within the joint itself. So probably it would work, but just that it may not be in an optimized condition. For a dislocation to be corrected, you need relaxation of the muscle for you to perform it. So I guess by using just intra-articular injection, it will not provide the optimal condition for you to perform the procedure. And I would probably suggest additional interscalene or supraclavicular block for you to have better condition to perform the procedure better, probably in less pain, and also patient will also have extended pain relief for longer hours beyond that. So to have an optimal condition for the procedure, I would suggest to have a block done. Probably you find intra-articular shoulder injection works, then maybe you can just supplement that with the blocks, either one of those techniques.
Okay. We'll proceed to the next question for Dr. Amin. Dr. Lokman from EDHDL would like to know, how do you choose the needles and what type of needles are available for use?
Okay, when you decide to choose the needle, a few factors you have to look into. One is the length of the needle. Okay, when we do the scalp scanning, means the preliminary scanning before you perform the real block, you have to decide and approximate the depth of the structure. Okay, so means from the ultrasound window, you have to look whether this structure is superficial or deep. So that's how you decide the length. So usually, I mean, in our population, we don't need more than 100 mm. In average, 80 mm length, needle length would suffice. Okay? So then comes the type of the needle. So there are a few types of needle in the market. One is the normal block needles, the old needles, I would say, the cheap needle. Okay, this needle is designed for not designed for a ultrasound guided block. So it's not an echogenic needle. So that's why it's cheap. So when it's not designed for echogenic, it's not an echogenic needle. So the image or the clarity of the needle on the ultrasound is not as good as an echogenic needle. So, but it comes with a higher price for an echogenic needle. So, if you have the budget, get an echogenic needle. Okay? So, let's say if you decide on want to buy which type of needle, I would recommend you buy a slightly longer rather than a shorter needle, because longer needle can be used a superficial block, but shorter needle cannot be used for a deeper block. So it's just safe. One needle can be used for all blocks. It's just that when you decide, when you perform a superficial block with a longer needle, you have to be careful when you advance the needle, especially if you have a crucial, structures like supraclavicular block, you have a pleura, below. When you use a long needle, just be careful that you don't advance too deep. Okay.
Thank you very much. Sixth question comes from Dr. Sopina of EDHL. I think Dr. Azrin can pick this up. It's since hip fractures are common in the elderly population, are there any dose adjustments for the elderly?
I guess when you consider the elderly population, it's basically the pharmacology of the drugs. They have a slower clearance of the drugs, and hence the blocks can last longer. But in terms of those adjustments, I guess for, let's say, hip procedures, if it is for Fascia, Iliaca, or even PENG block, the volumes that we use are actually 20 mils roughly, or even for Fascia, Iliaca block, you can go up to 40. If you have this concern of having slow metabolism and things like that, you probably can just use a more dilute solutions. But the volume you still need for the spread. So I think one of the studies done before has mentioned that for you to cover the three nerves, including the actuator nerve, you have to at least give 30 mils, depending on the body habitus of the patient. So you need the volume, but if you have this concern, you can further dilute the drugs to a more dilute concentration. So I guess volume-wise probably is the same, but you can actually adjust the mass of drugs by adjusting the concentration of the solution that you use.
Alright. Dr. Fadlina from Anaesthesia in HSA-JB is a question for Dr. Amin. Is there any difference in the outcome with different approaches of the Fascia Iliaca block?
Okay. To answer Fadlina's question, I think the different approach of Fascia Iliaca block is important for post-op analgesia, where you can give suprainguinal or infrainguinal. In terms of ED setting, mainly for analgesia, example for hip fracture or proximal femur fracture, I don't think either suprainguinal or infrainguinal approach make a huge difference. But for post-op analgesia, I would recommend suprainguinal approach, because the success rate of blocking the three nerves in the the aim of the three nerves, namely the obturator, LFCN, and femoral nerve, is higher. When you perform infrainguinal approach, probably you would miss the LFCN component or even obturator component. But I would say for ED setting, infrainguinal approach is as good as suprainguinal in terms of analgesia for hip fracture.
Okay.
Can I just add? I think one of the easiest blocks to learn is the femoral nerve block. So I guess if you perform femoral nerve blocks and also the infrainguinal lateral to medial approach, Fascia Iliaca block, it will not be much of a difference. So if you are familiar with femoral nerve blocks, for you to get familiarized with Fascia Iliaca block, you can actually perform the same technique for femoral nerve block, but just give 40 mils of local anesthetic. So basically the volume plays a part in spread, and for beginners, that is probably the technique, the first technique of choice if you want to learn Fascia Iliaca block. So I guess it's technically it is easier until you have managed to be comfortable with that, and you are comfortable with the sono imaging of the inguinal area, then probably you can proceed. So basically, in terms of technicality, probably the infrainguinal Fascia Iliaca block approach is easier. But in terms of coverage and efficiency, clinical efficiency, then the suprainguinal is probably better evidence-wise. So I guess those are the small differences between the two approaches.
Can I add a bit more on this? Actually, analgesia for trauma and analgesia for surgery is slightly different. Okay, when there's a bone fracture, you have a break in the periosteum, and that is where the cause of the pain, and immediately there are muscle spasms around. Around that example, femur fracture, you have all the muscles in the thigh. Okay, if you think carefully, actually the innervation of the femur bone supplied by the femoral nerve and the sciatic nerve. If you really want to give a total analgesia, a good analgesia, you have to block femoral and sciatic actually. But actually you don't have to do that. By blocking the femoral nerve is enough to give a very good pain relief, because by blocking the femoral nerve, you actually block all the muscles that supply to the bone. Okay, so reduce the spasm, and so your periosteum is not like going to be will be a bit relaxed because of the reduction in muscle spasm. So you will have, besides you blocking on the sensation, you are actually reducing the muscle spasm as well. So it's different from the surgical, post-op surgical pain.
Next question is also from Dr. Farina, possibly to Dr. Azrin. How do you determine the level of injection for ESP block in patient with multiple rib fractures?
Okay, basically for chest part, if you were to perform ESP, you have to remember that the ESP is a facial plane block. So and there's evidence to suggest that 20 mils of local anesthetic given within this space can actually spread up to cervical and also to the upper abdomen. So the thing is to just make sure that you are actually within the area where you can still see the rhomboids. So if you are in the rhomboids, you can see that the rhomboids are still within your field of vision, then it is safe to assume that you are covering the thoracic part of the blocks. So depending on which level, so I guess as long as you can manage to still see the rhomboids within the field of vision, then 20 mils of local anesthetic should be sufficient to provide coverage for multi-segmental blocks, multi-segmental fracture of the ribs. So I guess have to familiarize yourself to make sure that you are able to see the rhomboids.
Okay. Question number 9 comes from Dr. Nadia from Iliaca. How common are complications and how do we manage them?
Okay.
Back to Dr. Amin.
When you talk about complications, there are a few complications. I think usually in a complete RA workshop, we also talk about complications. So there are a few like local anesthetic systemic toxicity, peripheral nerve injury following blocks. Okay, that are the two common complications that people are afraid of. When you ask about how common, I think for talking about LAS or local anesthetic systemic toxicity, for the last 10 years in our setup, we only had once LAS incident out of probably 10,000 cases. My best guess for 10 years. Let's say we did 1,000 to 1,500 cases per year. So 10 years will be at least 10,000 to 15,000 cases. So we only had once. Okay. So that is what we should aim for when we perform the ultrasound guided regional anesthesia, reduction in complications. Okay, when we talk about nerve injury, the report from the papers actually depends on the reports. Some paper reports the incidence of nerve injury after blocks actually reduced, but some papers report it's not much difference compared to landmark technique. But the total incidence is actually very low, 0.04% to 0.5%, which is, I would accept the risk because it's very low.
Okay. For Dr. Azri, this might be indirectly related to the question earlier on, but the question is which type of block, ESP or the Serratus plate block, more suitable for anterior versus posterior rib fracture?
I think okay. If you go back to the anatomy, you know where's the coverage and where is the area that you need to provide analgesia. Then you can actually perform either one of the block. I guess for a Serratus anterior plane and ESP, mainly it covers the lateral branch, and you actually can block parts of the hemithorax between midline of the clavicle anteriorly to roughly about mid-scapular spine area. So if the fracture is within this area, then probably providing Serratus anterior plane blocks adequate. But if it is slightly more anterior and it goes medial to that, two rough guide, then you probably need an ESP. So if it's anterior close to the sternum or even just slightly medial to the midpoint of the scapula, then probably an ESP is better option rather than a Serratus anterior plane. But then again, it depends on the level of expertise, what type of blocks that you are comfortable with. Then you, at the end of the day, what the technique of choice depends on what you are comfortable with. So I guess primarily determined by where is the fracture and whether you can perform SAP or ASP.
Our last question of the day, addressed to Dr. Ami. Is serratus plain block a good option for chest tube insertions?
I would say yes. Okay, and of course you can also perform a Erector Spinae plain block, okay, for chest tube insertion, but serratus plain block is good enough. What you have to understand is the innervation of the chest wall, okay. As long as you can block the nerve supply to the area, that will be a good block.
Thank you.
Just to add, if you want to perform the block to provide pain relief for the fracture, then it is good to perform ESP. But only if for the chest tube, then depends where the fracture is. But just for chest tube per se, then yes, SAP is adequate.
Alright, so that are all the questions for today. Thank you very much, Dr. Ami and Dr. Azrin, for your time. And that concludes the webinar for today. I hope you have found the session very informative and eye-opening. I certainly have. And I can't wait personally to try this in ED. Before we conclude, just final reminders. On behalf of the organizers, I would like to apologize for any shortcomings during the session. Thank you again to all the speakers for sharing your precious time off today to share your knowledge with us. And thank you to all the participants for your attention. Have a pleasant weekend ahead and stay safe. Assalamualaikum. Thank you.